Hello everyone and welcome back to my channel. Today we have our latest installment in my ultimate review video series, which are a little bit more long form and more comprehensive and focused on a specific topic. Today we're going to be focusing on pigmented lesion of the oral cavity. Just like the other videos in this series, this is going to be more comprehensive and lecture format, similar to what I would give my dental students. As always, you can use the chapter tool below to skip between the entities. That being said, we still have the disclaimer that this video is for educational purposes only and should not be used as medical advice. Should you have any questions or concerns about your oral or systemic health, please see your nearest oral or systemic healthcare provider. In addition, all the opinions expressed in this video are mine and mine alone and do not represent any organization that may employ me or that I may belong to. And also, all of the photographs are either from my files or credited to where I've received them. And without further ado, let's take that deep dive into pigmented lesions of the oral cavity.
All right, so today we're going to be talking about pigmented lesions of the oral cavity. It won't be all of the pigmented lesions that are possible within the oral cavity, but it is all of the most common lesions that are pigmented in the oral cavity. So starting with physiologic pigmentation, it makes sense that patients that have more melanin in their skin may also have melanin in their oral mucosa. This pigmentation will be present from an early age and will remain throughout the patient's life. The patient will probably tell you that they've always had kind of more of a brown tinge to their gingiva. The melanotic macule is the most common pigmented lesion of the oral cavity, representing more than 80% of all of the other lesions that we'll be discussing. And the most common area for this to occur is on the lower labial vermilion, which is where I see them most in my patients, but they can be seen on the gingiva, on the palate, or on the buccal mucosa as well. If a patient has multiple, especially on the vermilion of the lips, it could be associated with a syndrome. These include Peutz-Jeghers, Lagier-Hunziker, and Leopard. And that's pretty significant because, especially with Peutz-Jeghers, where the patient can have colon cancer and can get colon cancer at a young age. So it's really important that if a patient has multiple melanotic macules of the labial vermilion, that they are referred appropriately, especially pediatric patients. Here's an example of a biopsy-proven melanotic macule of the gingiva. Melanocytic nevus is not very common in the oral cavity, not nearly as common as it is on the skin. The average is about 20 melanocytic nevi on a Caucasian person's skin. In the oral cavity, we don't see them very often. When they do occur, they usually occur on the hard palate or attached gingiva, and not all of them are pigmented. So sometimes the nevus itself is a texture change, and when biopsied, we see the melanocytes that we would see in a nevus. So there's no treatment required for these melanocytic nevi, and transformation is pretty uncommon, perhaps 1 in a million. Under the microscope, we see really benign findings. It's an unencapsulated proliferation of nevi cells. We call them theques, Thequus, theques. If you notice any change in the nevus, it's really nice to document these lesions photographically for your chart, for your files. If you notice any change or if the nevus is chronically irritated, then it's probably a good idea to excise it, both to rule out something more ominous and also for patient comfort. A blue nevus is a type of nevus, and it is a accumulation of benign melanocytes that are deeper in the tissue. And these are also a little bit more spindle. They're not as round and they don't stay in the clusters that we see in a normal melanocytic nevus. The reason why it's called a blue nevus is something called the Tyndall effect. And that is when you have light refracted in a certain way, as you're seeing in these two cups right here. If the light is refracted, everything but the blue wavelength is scattered. And it gets scattered because the melanocytes are deeper within the tissue. So by the time the light reaches our eyes, it doesn't appear brown, which is the actual color of the melanocytes. Instead, it appears blue because all of the other wavelengths have scattered. And you can appreciate that the cup that's further away from the light source is blue due to this Tyndall effect. Blue nevi are most common on the palate. A source of acquired pigmentation is the medication-related pigmentation. And this has kind of two mechanisms. The first is either the medication itself can stimulate melanocytes to create more melanin, or it's from direct deposition of the drug into the tissue. So if the drug gets directly deposited into the tissue, then it can create a brown pigmentation. This is associated with several different medications. One of the most common that we see is minocycline, which is used in chronic acne patients. And minocycline can actually cause deposition of the metabolites and may even be deposited in the bone. You can actually get kind of a green tint to the bone if you have exposed bone, if you lay a flap. Anti-malarial agents, such as hydroxychloroquine, can cause medication-related pigmentation. And you may be saying to yourself, oh, well, we don't really prescribe a lot of anti-malarial agents in areas where malaria is not endemic. And that's true, but hydroxychloroquine is actually used outside of malaria. It's used in inflammatory conditions. Sometimes I even prescribe it for my lichen planus patients. It's used in rheumatoid arthritis and systemic lupus erythematosus and other autoimmune and inflammatory conditions. Certain tranquilizers can lead to medication-related pigmentation, and the largest group where I've seen it clinically is actually chemotherapeutics. So patients getting Gleevec or imatinib, which is used in certain leukemias, can lead to this medication-related pigmentation. And least common is AIDS medications. AZT, which is one of the first medications for AIDS, did lead to medication-related pigmentation, but the newer drug therapies that are used don't necessarily lead to the same thing. So the likelihood of seeing an AIDS medication-induced medication-related pigmentation is pretty low. And discontinuing the medication results in gradual fading. It does take some time, especially if the drug is a metabolite. So if the drug's a metabolite, it'll get cleared over time. If it's an increase in melanin, it might take a little bit longer, but it can fade. It might never be completely gone, but it can fade with time. And here's a case provided by Dr. Kulagairu. This is a 53-year-old female who is a social drinker and a non-smoker with a medical history of hypertension and rheumatoid arthritis. And here you can see the classic pattern of medication-related pigmentation, and that is kind of this blue, gray, maybe black, brown, symmetrical throughout the palatal vault. Now, if you think about the palatal vault, the mucosa is thinnest here. This is where we have the mucosa bound to bone, and it is thinnest at the palatal vault, which is why we can see a little bit more medication-induced pigmentation here. But this is classic finding, and the patient has rheumatoid arthritis and is taking hydroxychloroquine, and therefore that's the cause or the source of the patient's medication-related pigmentation. Here's what you see under the microscope, just a collection of this excess brown pigment, and that's why it appears brown on the palate. Special stains of iron and silver highlight both the melanin and the drug metabolite. Post-inflammatory hypermelanosis or hyperpigmentation is more common again in patients that have more pigment throughout their body. And this occurs when the patient has an area of inflammation. This is often related to patients that have lichen planus. And I practice in an area with a high population from Southeast Asia, and they can get really bad lichen planus, just really, really ulcerative, really painful. And oftentimes, as that lichen planus resolves, they can get a post-inflammatory hypermelanosis or hyperpigmentation. And melanin is a protective mechanism. You know that when you are out in the sun for a long time, you get tan. That is the body creating more melanin to protect itself. And that's the same kind of philosophy here, is that the melanin is being used as a protective mechanism against the inflammation. Smoker's melanosis is kind of along those same lines. It's a possible protective mechanism against the smoke itself. So is this perhaps a version of post-inflammatory melanosis, or does it have a different mechanism? We're not sure, but I kind of buy in that it's a protective mechanism against that caustic smoke and all of the components of cigarette smoke. Facial gingiva is most affected. It's most commonly affected, and that's because it's what is exposed to the smoke. So when the smoke comes into the mouth, it's hitting that facial gingiva, especially anteriorly, and that's where the melanosis occurs. There's a phenomenon called reverse smoking that's exceedingly rare. It's only certain subpopulations in the world where patients actually put the lit end of the cigarette into their mouth, which seems both really dangerous and really unpleasant to me, but there are certain cultures that do that. And in that case, you can get smoker's melanosis of the palate and the palatal gingiva, because that's what's being exposed to the smoke. I've never met anyone that's done that, but it is something that is talked about when we talk about smoker's melanosis. Systemic conditions can also lead to color change in and around the oral cavity. Addison's disease is known for creating kind of a bronzed look, which may be reflected in the patient's oral mucosa, especially the gingiva. And jaundice is another. So you see the yellow eyes, but you might also see yellowing of the skin, and you might see yellowing of the gingiva and the oral mucosa. In fact, this picture here is not altered at all. This is a patient that we met that was awaiting liver transplant with kind of end stage liver failure, and this patient had pretty severe jaundice, and you can see that that's reflected in a very yellow gingival appearance, but this was not altered. You can see that their skin also looks maybe a little bit more brown yellow too. Melanoacanthosis is very interesting. It's a very specific pattern, both clinically and microscopically. So microscopically, we see a very specific finding, and that is these melanocytes that have these dendritic processes dispersed throughout an acanthotic, meaning a thickened, and spongiotic, meaning a spread out epithelium. This occurs primarily in African Americans, especially female, especially women, in the third and fourth decades. And this presents as a smooth, flat, or maybe slightly raised, dark brown to black. This is really intense in color. And not only that, but it rapidly increases in size. So the patient may say, I've never had this before, and all of a sudden it's huge. It's taking over my entire palate, or all of my gums, or all of my cheek, and I swear I've never had it before. And you might think, oh, well, maybe this is physiologic pigmentation, because a lot of these patients have melanin in their skin, but it's going to be more intense in color, and the history of sudden onset is a big hint. The issue is, when you have sudden onset and huge and rapid increase in size, you start to worry a little bit about malignancy, right? So malignancy pops up out of nowhere and can grow rapidly. So oftentimes, or really probably always, a biopsy is indicated, even if this isn't the primary group that we worry about for mucosal melanoma. You still want to rule it out. So you will biopsy these patients, and oftentimes this will spontaneously resolve after biopsy. So the pattern is that it pops up out of nowhere, gets really huge, you biopsy it, and then you have the patient come back for follow-up and it's gone. There's no documented transformation in melanoacanthosis. Here's another case of a 17-year-old male who did have eczema and had post-inflammatory pigmentation on the skin, but not in the oral cavity. And the history was these lesions presented suddenly and have only been present for a week. And here we can see on the left buccal mucosa an intense brown, black, diffuse color change. Here's the right buccal mucosa. There's a little bit of leukoedema in here, but you can see this really kind of diffuse area of really deep pigmentary color. Here's some on the gingiva that probably is physiologic, but might be related. The gingiva can lead to melanoacanthosis. Here's the biopsy. So we have this thickened, which is acanthosis, and spongiotic. You can see kind of the spaces here between these epithelium. It looks like a sponge maybe, where it kind of is spread out. And right here, we can see a brown cell with kind of little spokes or dendrites pushing off of it. We take a closer look. And here we can really appreciate these dendritic melanocytes. There it is, but we can see throughout this really wide spongiotic epithelium, these dendritic processes, these little fingers, these little snakes that are kind of weaving its way through this epithelium that's spongiotic or all spread out. And here's what we're really worried about, mucosal melanoma. And this is a malignancy of melanocytes. It is not common in the oral cavity. There's 1.2 per 10 million cases of melanoma are mucosal in nature, and that's all mucosa. So, you know, you can get mucosal melanoma of the conjunctiva, of the nasal mucosa, the anal mucosa, but less than 1% of melanomas are mucosal in nature. When these occur, they often occur on the palate or the maxillary gingiva. They can occur on the other gingiva, but gingiva is the red flag here. A lot of these, the vast majority occur on the gingiva. And 50% of melanomas, and these are melanomas of the skin, have a BRAF mutation, and there are targeted treatments for against BRAF if the patient has a BRAF mutation in their melanoma. And in mucosal melanoma, we often see a KIT, especially c-KIT gene mutations, but these are more sporadic and they don't respond quite as well as skin melanomas do to targeted therapy. And mucosal melanoma is much more aggressive than cutaneous and has a worse prognosis. In fact, mucosal melanoma is automatically stage 3, automatically right off the bat. Even if it's small, it's automatically stage 3, according to staging guidelines. Most of these are stage 4 at the time of diagnosis, which is the worst stage. The way to treat these is radical surgery with chemo, but this is really a poor prognosis. Even with surgery, it recurs pretty rapidly, and patients don't do well, unfortunately. And it is a dentist, believe it or not, based on what you're going to see, who is in his 7th decade with this gingival lesion that's present 8 months. And this is pretty obvious that this is not good. You can see that there is a lot of change in color here, that it is nodular in nature, it is a tumor, it's swelling. And yes, this is a dentist, despite all of the plaque and despite this massive tumor that has reportedly been there for quite some time. Here's the occlusal view. You can see that it's both facial and lingual for the teeth. And under the microscope, we see these nasty, some of these cells are pigmented, some of them are just purple in nature, the purple in color here, that's not good. And here we can see irregularity, we call that pleomorphism, as well as a mitotic figure. And we've got some big scary nuclei that you can appreciate down here. That's a lot of hyperchromatin. There's excess chromatin there because the cell's trying to divide. And here are some more just really nasty looking pigmented cells in this patient's melanoma. So is melanoma always obvious? That case is pretty obvious. Unfortunately, if that patient were to walk in, you'd say, yeah, that's melanoma. But the answer is no. And this is a really important case, I think, to look at. And early melanoma can look like a melanotic macule or a nevus or a blue nevus or an amalgam tattoo, which we'll talk about here shortly. And biopsy is important to rule out melanoma. So you don't want to assume something's a melanotic macule and miss an early melanoma, because a stage 3 melanoma that's localized probably has a better chance at long-term survival than the last case that we saw, where it's already nodular, it's already very large. That's definitely stage 4 disease. But this melanoma that you see here, taken from our journal, Quado, is probably a much better prognosis, still a guarded prognosis, but better than the case that I just showed you. My rule of thumb is that if there is a pigmented lesion on the gingiva, it should probably be biopsied. And by probably, I mean definitely. It really should be biopsied if you have a pigmented lesion on the gingiva, because you don't want to miss a melanoma. Some of the warning signs for this lesion here is that there's variegation of color. So there's multiple colors in here. It has an irregular border. It's larger than the tip of a pencil. It's kind of some of the same guidelines that we use in skin melanoma, the A, B, C, D, E's that we use in skin melanoma. It's asymmetrical. It has irregular borders. It has color variegation or different colors. The diameter is larger than 6 millimeters, or the eraser side of a pencil. And then the last is evolving over time, which is something that the patient would have to tell you. And here's the case that I've seen in my practice. It's the only case that I've seen of mucosal melanoma. And this patient claimed that they'd had this for a long time, but what had me worried is that, you know, we've got kind of irregular borders here. It's multifocal in nature. You can see it both on the buccal and the lingual. You can see that in this island, we've got kind of multiple shades of brown here. I was very nervous about this, so I performed a punch biopsy. The biopsy site that I actually took was right here because I wanted both sides of that color change. And this ended up being melanoma in situ, which is not quite invasive melanoma, but it still is not good. This person had atypical melanocytes. But this is exactly what I'm talking about. You don't want to kind of wave this off as physiologic or as reactive or as a melanotic macule. This really needs biopsied. So now we're getting into the more iatrogenic or the more acquired. Again, just like the medication related, these are acquired, meaning they're not present from birth or they're not something that the body is naturally produced. So intraoral tattoos, intentional. When we're talking about outside of labial mucosa tattoos, which we'll talk about here briefly as well, the intraoral tattoos are usually of the anterior maxillary facial gingiva. These come from individuals that are originally from a number of African countries, especially the Eastern African nations on the Horn of Africa, such as Somalia, Eritrea, and other neighboring nations. Initially, these tattoos are dark. They're more black or perhaps a navy blue, and it fades to gray over time. And for you, this is a middle-aged woman who presented to the intake clinic at a dental school, specifically my dental school. This was at Ohio State, and she recently emigrated to the United States from Somalia. So this patient was my patient in dental school. And when she came in, I was already interested in oral path. I knew exactly what was going on. Columbus, Ohio at that time had the second largest Somali refugee population outside of Minneapolis, Minnesota. So Minneapolis, Minnesota was number one, and Columbus, Ohio, where Ohio State University is, was number two. And here's my patient. You can see that she has this diffuse kind of blue-gray pigmentation of her facial gingiva. It was not present on the palate, and you can see it wasn't present on the mandible. This is a sign of beauty in her culture. This ended up being an excellent patient. We ended up forming a close relationship, her, myself, and the translator, Muhammad, we always had the same translator, so the three of us always spent a lot of time together. She ended up being a partial denture patient for me, and she was one of my most reliable patients. But she had this really interesting finding. If this looks familiar, I do have a YouTube video where I talk about this case a little bit more, so you can check it out. And we know that labial mucosa tattoos are something that we like to do here in the United States. I've seen a wide variety ranging from innocent to pretty vulgar. I also a story from dental school. I remember I was doing my extraoral and intraoral exam on a graduate student, and she didn't give me warning, but I pulled back her lip and there was a vulgar word, but she was very put together. She had just come from teaching, and so I was pretty caught off guard by her labial mucosa tattoo. But there are certain people that find this beautiful too. So the tattooing of the gingiva might seem strange to us, but this might seem strange to other people. This is an interesting story. This is a resident that was a resident that overlapped with me during my residency. And apparently Shine is the name of a band. And this person got their tattoo at 18 thinking it would fade. That's kind of an urban legend around these. Yes, some of these do fade over time, but I've had quite a few people that said, yeah, I got this thinking it would go away in a few months, but it's been years. And that was true with this person right here. She ended up getting an aphthous ulcer at the base of the E. So her shine was previously shine, but the aphthous ulcer, the inflammation actually took away the pigmentation, took away the ink. So now her tattoo reads Shink, Shinc, since the E was lost by her aphthous ulcer. This is on my oral pathology bucket list. This is called susuk, or charm needles. Patients get these embedded into their oral mucosa and their skin of their face as a good luck charm. In certain, certain East Asian populations, Indonesia, as well as Malaysia and other countries in the region. Closest I've come is acupuncture needles. There's some practices of acupuncture where they actually leave the needles behind in the patient's skin. Amalgam tattoo is very common. You're going to see this very frequently. I see this weekly. Patients refer to my practice for amalgam tattoos. These are iatrogenic, meaning caused by a provider. These are gray or blue-gray macules that are evenly pigmented. So you might have a white line in the middle where the area of trauma occurred, but for the most part, they're kind of just this spot of blue-gray. And they're right next to an amalgam restoration or perhaps a crown. If the patient has a crown, they probably had a buildup or a large amalgam filling under it. You might have an apicoectomy where the backfill was done with amalgam, and that's what you can see in this case. You can see that there's a tattoo here, but when you take a periapical radiograph, you can clearly see the amalgam there that was embedded. In fact, if you take a radiograph here, you can take a soft tissue radiograph where you don't get the patient's tooth, but you can put the sensor in between the patient's alveolus and the cheek. You can take a radiograph and see if you see the particulate matter. The issue is that the amount of amalgam may be really, really tiny, and you might not even pick it up on radiograph. So you might take a radiograph of this lesion and not see any little radio opaque flakes of amalgam, and that's okay. As long as it's on the movable mucosa and it's near an amalgam tattoo and you're going to monitor it, then that's okay. We get a little bit more concerned when it's on the gingiva and the patient doesn't have a history of amalgam or doesn't recall a history of amalgam. That might require biopsy, but it is something that you'll want to watch over time. You might also see this on an alveolar ridge in the area of an extraction. That could be from a patient having an amalgam restored tooth extracted, and during the extraction, part of the amalgam chips off and then becomes an amalgam tattoo in the tissue. You have to rule out graphite tattoos. So if patients are, I had a patient once that was walking around with a pencil in their mouth. They had the writing end in their mouth. They got hit and the graphite, the pencil, got lodged into their palate. So they had a nice blue-gray spot from a pencil in the middle of their palate, away from where an amalgam tattoo would be expected to happen. But they knew the history. They knew that they kind of stabbed themselves with a pencil, and we were able to pick it up on radiograph. Now, oral mucosal pigmentation has a lot of different potential etiologies, including systemic diseases, like we talked about with jaundice and Addison's, deposition of endogenous pigmented material, so pigmented material from inside the body, like a melanotic macule, or exogenous pigmented material, like an amalgam tattoo. post-traumatic or inflammatory hyperpigmentation, like we talked about in lichen planus patients, normal pigmentation, smoking-related pigmentation, and one more that I would add, which is neoplasia, so our nevi and our melanoma. Thank you for watching, and feel free to reach out with any questions that you may have.
There you have it. I hope you enjoyed that comprehensive review in my ultimate review series on pigmented lesions. Feel free to check out the other videos in this series by looking at the link below. I put them all into a very convenient playlist for you. Of course, if you haven't already subscribed, please hit that subscribe button as well as that like button while you're down there. Thanks again for watching, and be well.